Infectious from Cairo University, Egypt. In a perspective published on 2013 from the GDD Global Disease Detection Operations Center at the US CDC, EV71, enterovirus 71, was known one of the top 5 global infectious disease threats to watch. Among the avian influenza, H5N1, the second ranked in the list was cholera, the third wild polio, and the fourth was EV71. And the fifth is the extensively drug-resistant tuberculosis. My presentation about control and management of enterovirus 71 associated hand-foot-mouth disease. My aim will be to overview the outbreaks of EV71 associated hand-foot-mouth disease and to describe the prevention and control measures associated, including vaccine. So hand-foot-mouth disease is one of the most common recognizable febrile viral disease in children, most frequently caused by Coxsackie virus A16 and EV71. It's a mild disease. However, the EV71 associated hand-foot-mouth disease outbreaks has shown high incidence of severe neurological symptoms or complications like brainstem encephalitis, meningitis, and acute flaccid paralysis. Fatalities have been reported in children less than 5 years. However, as regard the age vulnerability, it has been shown that the age at 1 to 3 is the most vulnerable to get serious complications. EV71 associated hand-foot-mouth disease is a serious public health threat and a burden to any healthcare system who faced such outbreaks. What about enterovirus 71? Enteroviruses are non-enveloped single-stranded positive sense viruses in the Picornaviridae small RNA virus family. And such group of viruses are phylogenetically classified into 4 species, species A, B, C, and D. Enterovirus 71 is a non-poliovirus that belongs to the A species. And it was first discovered in California in 1969. Schmedet et al. In 1974 has reported 20 cases of EV71 infections with 1 case of death, and it was belonging to enterovirus species A. Global insights were gained on the genotypes and subgenotypes of the virus. So we have 3 main genotypes, A, B, C, and for B and C, they are further classified into subgenotypes B1 to B5 and C1 up to C5. As for genotype D, it has been identified in India, whereas E and F has been identified in Africa. And rare subgenotypes like B0, C0, and C2-like have been also identified. In the past 4 decades, many countries all over the world, whether in the US, Asia, Europe, South America, all these have been faced with the EV71 outbreaks. It occurs in a cyclical pattern every 2 to 3 years, predominantly caused by strains that are changing from outbreak to another outbreak. So we are going to show the major outbreaks that occurred throughout the world after its first discovery, as we said, in 1969. So the first outbreak, it was in Europe during 1978 and 1975 and in Bulgaria, and in 1978 in Hungary. And as you see here, the number of cases that were infected and presenting with aseptic meningitis, bulbar encephalitis, in both Bulgaria and Hungary, and the fatalities were 68 in Bulgaria and 45 in Hungary. And then, as you can see, it can be seen that it is skipped in the 80s. No, it was not. During 86, although outbreaks occurred, but we are talking about the case fatalities. There were no fatalities. In 86, Australia has been attacked with around 115 cases, but no reported death. And in 87, in USA, there were 45 cases of infection, but without any fatalities. Then in Malaysia in 1997, there was around 6,000 cases and more than 35 cases of death who died from the cardiopulmonary failure. Then we go in 1998 in Taiwan, where there was more than 130,000 cases with 78 cases of fatality. Then in the following decade, in 2008, China is, as we said, to date, China is considered the most populous country in the world and the most country that has been suffered from such outbreak. In 2008, there was around more than 500,000 infected cases with 1,000 fatalities. And as you see, from 2008 up to 2012, the number reached to 7 million or more, and the fatalities more than 2,500 cases. And this can direct our attention to the extent of the disease burden, as we said. And here we go for Korea, who was attacked in 2009 with the outbreak, 91 infected cases with 2 cases of death. In this slide, the upper part, we will have the some publications in countries like Denmark, France, and in Sydney. It shows the individual infection reported cases. So as you can see here in Denmark, during 2009 to 2012, there was 63 cases with neurological disease. 6 out of 63, it was the classic hand, foot, mouth disease. While in France, in 2012, they reported 4 cases with neonatal fever and meningitis. In Sydney, this publication was in 2014, reporting the 120 cases with severe diseases. 28 of them was the classic. However, in this publication, the one in 2014, discussing the outbreak that happened in metropolitan Sydney, they stated that there has been a limitation in this study, that they didn't have the power to report the what's called the subgenotype. And while in the previous studies in Denmark and France, the subgenotype was C4. And here in the lower part of the slide, give you an idea about the 2 most important pandemic subgenotypes of the EV71. We have the C4, and this was discovered and reported in Europe since 2004, and in the epidemics that happened in China from 2008 to 2011, in France as a part of Europe in 2004, and as we said here in 2012, it was reported again. and in Denmark it was also reported in 2012. The second strain, which is important to cause large outbreaks, D5, and it was discovered in Malaysia in 1999, in Japan in 2003, Denmark in 2007, and in Taiwan during 2008 and 2012, and lastly in France in 2012. These are the two, as we said, virulent, neurovirulent strains that cause not only large outbreaks, but it's the cause for the severe life-threatening neurological complications. Now we go to the clinical spectrum of hand-foot-mouth disease. Hand-foot-mouth disease, it's a spectrum. At one pole of the spectrum, you may find the localized form of the disease inside the mouth, which we call it herp angina. Herp angina is characterized by localized sores inside the mouth, while in the other pole of the spectrum is the classic hand-foot-mouth disease, which can be affecting not only the mouth like the herp angina, but it will also affect the palms and soles of children, as well as other body parts like the buttocks and upper thighs. The incubation period of this disease, it takes nearly 3 to 5 days, and it is transmitted by a fecal-oral route. And here we have to stress about the route of transmission, as we can see in our preventive measures. So the classic disease, as we all know, it's a skin disease. However, it has a clinical grading which can progress from the uncomplicated skin disease, which is characterized by fever, vesicular papular eruption, as we said, in the oral mucosa. If the oral mucosa only, it is called herp angina. If it is proceeding to the hand, foot, and buttocks, it will be the classic hand-foot-mouth disease, as case definition was reported. And then when it progresses to involve the central nervous system, it is graded 2. And when we have heart rate variability, which is a specific index to the autonomic nervous system affection, it is graded as 3, while when it ends in a cardiopulmonary failure, and this is stage 4. What about the complications? We have acute severe complications with high mortality, which include pulmonary hemorrhage, brainstem encephalitis, aseptic meningitis, flaccid paralysis. And here also we should stress upon what's called critical cases. Critical cases here are defined as when you have a disease condition that has been complicated with pulmonary hemorrhage or cardiopulmonary failure. It is called or defined as a critical case. Now, what about the prevention and control measures? First, we should know that establishing and strengthening a surveillance system is one of the most important measures for controlling the EV71 associated hand-foot-mouth disease. But what we should know that hand-foot-mouth disease has not been a notifiable disease in most of the countries until lately. Lately, we are talking about 2008. And it's not a matter that you have to report each case of hand-foot-mouth disease. It will not make any significance. The reason to have, as we said, strong surveillance system, that you should have in your reports information that could predict the event or the seriousness of the disease. So it should include the severity of cases, and from that we can have good data. Another thing about the surveillance, that currently we don't have what's called international network for specific for hand, foot, mouth disease. And this is one of the needs in order to make exchange of information between those countries who have been affected. So what about the strategies that can effectively control and prevent the spread and diffusion of hand, foot, mouth disease? The most important here to reduce the transmission rate by popularizing the healthcare education and teaching good hand hygiene practice. And here I should thank Dr. Ajaz, who has stated in the first day the importance, and I absolutely agree with him about hand hygiene. This is the core, and as we go further in our study, it's still the only simple available measure that we have to work on in order to reduce the transmission rate. So thank you, Dr. Ajaz. And I think also during any conference that is related with healthcare professionals, nobody can go out from a conference room without hearing about hand hygiene. So frequent hand washing before and after eating and after going to the toilet, avoiding thumb suckling and nail chewing, and putting a face mask when feeling unwell. All these should be followed. And also, we have to strengthen the infection control practices in hospitals in order also to avoid the nosocomial cross-infection. Then we shift to another measure to increase the recovery rate of non-hospitalized cases, and also we have to train our healthcare professionals how to deal in a timely and adequately fashion with clinical case management. Other factors here, there has been no concrete evidence that when you close the school, this will reduce the infection. Many health child care facilities and schools usually closes when they have fears about the infection. But up till now, no specific body like CDC or WHO, there is no concrete evidence that closure will reduce the transmission rate. So this is about the strength of evidence, and as we can see again, the most important one in this is the hand hygiene. Now, what about the treatment? If we are talking about the classic hand, foot, mouth disease, it's usually symptomatic. You have fever, you have a skin rash. It's a self-limiting disease. But what about if you have the complicated form? Many antivirals have been reported in the literature. Among them is the intravenous immunoglobulin, which acts to suppress the viral replication, and it limits also with anti-inflammatory activity the organ damage. This has been reported in 2007. Also, drug like ribavirin and type 1 interferon, it works as a protective effect on the enterovirus 71. Pleocarnil is another drug which has a broad spectrum activity against various enterovirus 71 serotypes, but it has no cytopathic inhibition effect. As you can see, this is part of a long list, but all of them, we don't have an effective antiviral up till now. Why? Because of the high frequency and recombination of the virus. Now, what about the future? Of course, when we are talking about vaccines, it's one of the most effective approach to prevent the outbreaks. But let me give a history about the development of the vaccines. In Bulgaria, as we said, it was attacked in 1974. After this attack, they started to work to develop a vaccine. And inactivated vaccine. It was worked in a Moscow laboratories in 1975. But due to practical reasons that Bulgaria was not attacked again by an outbreak, the project was stopped until it came to life again in China, where they started to work to develop the vaccines. As we said, it's the most country that has suffered from the outbreak. However, the efficiency data published only 5 years after China made the hand-foot-mouth disease a notifiable disease. And Liang and Wang, they summarized and put very good work about the results of three clinical trials, phase 3 clinical trials of the inactivated EV71 whole virus vaccine in the mainland China. It was given as on 0 day and boosted after 1 month. And voluntary surveillance, whether for the hand-foot-mouth disease development or herpes angina, in a 1-year follow-up. The vaccine strain here, it was used the C4, and as we mentioned, it's one of the pandemic strains with nucleotide differences ranging from 97.3 to 99. The amino acid differences, it was 98.3 up to 99.7%. So, what about the vaccine efficacy? We had three companies, Sinovac, Vigo, and Kunming Institute. The total number of patients, it's nearly 30,000 patients. Half of them were enrolled as a vaccine group, and the other half was a placebo group. The age of all infants enrolled ranged from 6 months up to 35 months. And here we can see the different results. It was followed here after 6 months, giving the 97.5% efficacy, and after 12 months it was reduced to nearly 95. Here in Vigo's study it was 90%, and in Kunming it was ranging from 92 to 99, mean 97.3. So what about the safety of this vaccine? Sinovac, Vigo, and Kunming, they noticed the common adverse effect. It was fever less than grade 3, and it was compared to placebo. And here we can see, according to Sinovac, it was 41% to 35% placebo, 35 as per Vigo, 35% versus 33.9, and in Kunming it was 34.6 versus 35.1. While for the severe adverse events, it was reported nearly 1.2%. Although the safety is clear, but the rate for the preventing hospitalization for the clinical trials, it was 100%, and this is also good about the virus. A 1-year follow-up, it was missing in the Kunming Institute study, but we have it on the Sinovac and Vigo, and it ranges from 99% to 92 as per Vigo's trial. So we have here some major key points of the EV71 vaccines. First, how to persuade the public to accept hand-foot-mouth disease is still epidemic even after vaccination, and also the urgent need to establish WHO guidelines to accelerate vaccine application. So one of the major points to promote the vaccine application. The second thing, what about the cross-protection of this EV71 vaccines? We said we have 2 strains. When they made the vaccine containing C4, it showed good cross-neutralization against B4, B5, C2, and C5 subgenotypes. This was not the case for before containing vaccine. It was unable to neutralize C2. So this is one of the major point, another major point that should be considered. The third point here is monitoring the safety and effectiveness. We had only 3 clinical trials, and it is in the phase 3, and it is conducted only on 30,000 infants. We need large population size in order to monitor the vaccine safety and effectiveness. In this slide, this will be my last slide, and this taken from a publication on May this year, 2015, and this was the work of Koch, who has described the different vaccines, but as we stated in my previous slides, this is our vaccine, the inactivated vaccine, because this is the only one in the list who had clinical trial phase 3, while the rest still in vivo and in vitro. So what are the advantages? If you are using a live-activated vaccine, it's a broad spectrum low cost, but incomplete attenuation is a disadvantage. When we use the inactivated vaccine, inability to replicate, but it is high cost. When you use the subunit vaccine, it's safe to use, but low immunogenicity. Synthetic peptides, it's safe and small, however, also of low immunogenicity. Virus-like particles, safe to use, but unstable and need purification, plus it's high cost. Finally, DNA vaccine. DNA vaccine, it's resembling the native virus, fast production, low cost, but low neutralizing effect. So my conclusion, EV71 associated hand-foot-mouth disease outbreaks have occurred for decades with severe complications and death in children. Frequent mutations have hampered the development of effective antiviral up till now. EV71 vaccines are eagerly awaited, but as you see, there are several challenges to overcome to save lives and ensure health and welfare of children with EV71 associated hand-foot-mouth disease. So the last message, as I said during my lecture, still what's available and simple and easy to work on teaching or educating the parents, the healthcare professionals, and that's why when I submitted my presentation, I submitted under the public awareness. This is what I should stress upon. Thank you.
Thank you, Dr. Ismail, for giving this wonderful lecture. Are there any questions? Yeah.
Thank you very much for your comments and excellent presentation, by the way. Since you mentioned that these are enteroviruses, they are not stable, mutation is high. So what was the rationale behind picking a particular type and turn that into vaccine? That's one thing. And how they are following up if there is no mutant emerging?
Yes. As we can see, there has been many publications since the first discovery. And until, let us say, the early 2000, they started because what they were doing before, it was only serological to know if you have the virus or not. And then with the advances of the technology and the lab diagnosis, they started to know more about the genotype and the subgenotype. From this, as I mentioned, since 2004, they started to know what happened in Europe, what happened in China, and so on. It was due to C4. So they have two choices. From the company or the manufacturing industry point of view, I have only, this is the most reportable strain. So if I'm going to invest my money and my research in this, I have to select according to the publications. So that's why we have only right now, as regard the inactive vaccine, we have the one C4 containing and the one B4. Even B4, it was not reportable, but this where Singapore have made up till now phase 1 clinical trials. So what's running right now in China is C4. And that's why also when they are making right now new publications, this is an exciting to them. When you find this subgenotype C4, it makes panic. Okay, so this is the rationale about the preference. The preference is the literature.
Thank you. There's a question from Dr. Cups.
As a clinician practicing in India, there's hardly a day when HFMD is not there in OPD. On an average, 2 to 3 cases I see every day. And particularly in October and April, there is a peak. Now, fortunately, we do not have much neurological problems, so probably Weber strain is more of toxicity in this. 3 things, clinical picture, which is more compared to what you say. One thing, there is a lot of lesions at buttocks. I mean, hand,
Yes,
foot.
yes.
Matter of fact, we are tempted to label it as hand, foot, mouth, buttock disease. You know, that is.
I agree.
Second, the thing is, after nearly 40-45 days of sickness, there is a significant nail dystrophy. Many of the children, their nails would fall off, there would be ridges and all that. What is known as anachomadesis. Third thing, good number of patients which we are getting and becoming serious, going into ICU, are because of myocarditis, and less, we are getting more of myocarditis rather than encephalitis.
Yes.
Maybe it is because of strain different. We do not have much of EV71 in our country till far. Maybe it is missed, I can't just comment about that.
No, I agree with you. Of course, when we are talking about the EV71, because we need to focus about the severity of the disease and its progression to complications. Of course, in the other parts who I did not mention in my presentation, these are who are facing on daily basis this disease in their clinics in a mild form. Maximum, it will range to stage 2, stage 3 complications. But not, of course, I agree also, there are different strains, but what we are stressing or focusing here about the EV71.
We had a discussion about using vaccine in our country.
As you can see here, I didn't mention India. India is away from this. Yeah.
But the thing was the same again. If you promote it for HMFD, in that case, HFMD because of toxicity will not be covered at all.
And the Coxsackie A also will not proceed to the same
so there is no
complications. It is. Thank you.
Thank you. It's our last question. Yes?
The high rate of communications between the vascular or the polymerase is used in the amplification of its genetic material, and this is it affects the rates of infection after 2 or 4 years. For example, pandemic and
Yes. What was published in the literature that in every decade you will have one outbreak. Okay, and it's not necessarily that you have been attacked with one strain to be attacked again with the same strain. At every decade you will have a change due to the mutation. Yeah.
so the polymerase is used have no autocorrective activity.
What do you mean about polymerase as a diagnosis?
Polymerase activity, for example,
No, I don't know.
in order to keep the fidelity of replication.
No. I have no answer. Okay, thank you.
Thank you, Dr. Ismail, for giving this presentation. I give you the certificate of recognition. But I also would like to ask Professor Dimitri to come forward, and you are not allowed to go yet. Please come forward. Because I also would like to give you the certification of recognition for sharing the session, which is coming now. And the same for Professor Dimitri. So I can relax. And you're going to continue sharing the session. Thank you.